righty. Hi, everybody. Thank you to our chats at the back today. We have Dr. Camila Pulgar with us. I'm really, really happy to have Dr. Pulgar here. I absolutely love every single thing that you do. And I know you're very, very passionate about talking about suicide itself. So that was one of the things that I was very eager to be able to talk to you about today. We have some really great questions to dive in today, and hopefully we'll have time to dive into all of them. But before we jump in, and I will let Dr. Pulgar introduce herself. Before we dive in, I wanted to just remind folks that couple reminders at the back. We still have the community clothing exchange going on. So if there's something that you want to go in at the back and check it out, see what we have, see if there's something that you want to take with you. If there's something you want to leave, you're welcome to do so. And the other reminder is about, there you go. We still have the refueling station going on. So you need a snack. There's like at the back side of the back, we have some snacks going on and some drinks. So come on by. It's a take what you need, leave what you can. And so if you also have some stuff that you would like to leave for other students, you're more than welcome to pass by. And then I don't have any other image to share, but just as a reminder, in 2 weeks, we're also going to welcome Carolina Guizar, a dietitian that will be talking about mental health and nutrition. And so with that, Dr. Pulgar, so if you could tell us a little bit about who you are, and then we'll go from there.
Yes, hello, and thank you, Melissa, for the invitation, especially to talk about a subject that's so important to my career and also my personal life. So I'm excited to spend the rest hour with you all talking about suicide and suicide prevention. So, as you know, my name is Dr. Pulgar, and I am actually an alumni of the CED program. I finished my doctorate last year. It feels unreal that it's been a year, so here we are. And I'm currently a faculty at the Department of Community and Family Medicine at Atrium Wake Forest Baptist, where I conduct actually a research agenda around suicide and suicide prevention with the Latinx community. I'm also a licensed clinician, and I see clients or patients, how they're called in the hospital, but all of them are Spanish speaking and within the community that I see here, and most of them do have suicidality and mental health challenges that are important to note when we talk about suicide and suicide prevention. So very excited to be here today and look forward to the questions. If we don't get to all of them, I'll make sure to send over some resources with Melissa, and yeah, let's get started.
All right, let's jump in with the first question. So the first one that someone submitted was, what are some protective factors for suicide prevention? And there seems to be like some follow-up. So you can go address them in whatever order feels better. Yeah. And it says, so, okay, so what are some protective factors for suicide prevention? Also, what do current trends look like for minoritized youth? Which developmental age is most affected by suicidal ideation? Oh, you're muted.
I'm muted, sorry. Sorry about that. That is such an important question, because in my work with the American Foundation for Suicide Prevention, you know, the word prevention is in the title, so we work and advocate for prevention practices and mechanisms that support our communities. But I think as clinicians and as community members, we can all play a role when it comes to prevention. But to me, you know, there are a couple of ones that are key, and one is to ensure that we create a world where folks can talk about suicide without feeling judged or stigmatized, or that they will be made fun of, or that they will be dismissed, or you know, usually people sometimes are told, you know, that's all in your head, or how dare you think about something like that. And the reality is that it's such an important and normal part of life. Like, we all at some point in our lives either struggle with those thoughts either ourselves, or we know someone or love someone that has struggled with suicidal thoughts. So I think for me, one of the things to create that kind of environment that everyone can speak about their suicidality in a way that they are met with compassion and understanding and are supported to reach out for resources, which then leads me to my other priority, which is the access to a culturally sensitive, to a affordable mental health care system, which we don't have right now. I mean, there's a ton of barriers, for systematic barriers for, especially in my work with the Latinx community to reach that professional care. So it makes it really even harder. Like if people do say or do express suicidality, it's hard for them to reach the care and services that they need. So I think the second priority would be that we make those systematic changes so that people do have access to affordable and culturally sensitive care.
Mm-hmm.
And then I think, there are certain systems within our society that play a key role. Like, for example, schools are an important place for those resources to be present. So I think making sure the schools have the funding and the support for school counselors to support suicidal youth, I think is important. The church is also another system that's important to consider when we talk about suicide prevention. For years, some people might have heard from their church that suicide is a sin, so it's not something that you're supposed to talk about, right? So making those culturally informed presentations maybe to the church and resources to them to kind of change that mindset a little bit, to make sure that people do have a place to go and are able to seek resources when they're in a suicidal crisis.
Mm-hmm.
And what was the second part of that question?
The second part of the question was like, what are the current trends look like for minoritized youth?
Yeah, that's a very cool question, because so right now, if looking at the most recent statistics, within the pandemic, we have seen an increase of suicidal rates across the board, right? So but specifically, as with anything related to the pandemic, we are aware that our communities are more marginalized, tend to have a harder time accessing services. They also have higher rates of COVID cases, and harder time reaching those resources. So similarly, in a similar threat have been coming up in the research within suicide within the pandemic. And in 2019, our Black youth are the ones that have had the highest rates, especially between the ages of 18 and 24. So that's kind of like the emerging adult age. But we are seeing, unfortunately, a mystifying child suicide increase. And I will send you all that article, because it actually just came out yesterday in the New Yorker, kind of speaking to that. And unfortunately, for suicide, for youth suicide, there's so many, and the same way that suicide itself is such a multi-dynamic, multi-layer issue. But for youth, you have the exposure to bullying, the mental health challenges that have not been addressed, the trauma, the stress within the family, and for them during the pandemic, their life completely changed. I mean, they were taken out of school and their routines changed and all that. So I think the way that statistics looks right now, like, and without getting too deep into the numbers, but it's not great, like, especially for suicide for our youth. The rates are increasing for our Black and minoritized youth, are definitely increasing, which is definitely an issue that we need to address, either by increasing the research, because that's the piece that is challenging in this field, is that there's really, because suicide prevention is not a one size fit all, like it's not a one intervention will help everyone. there needs to be research and clinical work that is specifically tailored with our communities in mind. And that's why for me it's so important to create a research agenda that is not comparing Latinx folks to other groups, but is doing the work for them and alongside with them, and kind of involving them in every aspect of the research so that we can create interventions that make sense for them and that speak to the cultural strengths that we have within our community. But for sure, the suicide youth is definitely a problem right now, and what I would call a national crisis, because I think we all need to ensure that we're doing our parts. But I also think at a government level, more funding should be allocated for suicide prevention in our youth.
Yes, yes, absolutely. Um, the follow-up question was which developmental age is most affected by suicidal ideation?
Mm.
And I think I heard a little bit of that in your answer too.
Yeah, so the research shows that everyone can struggle with suicide. Like, it's not really like a age limit or age start for it. But because the research has mostly been done with emerging adults, so that 18 to 24 age range, there has been some research with younger folks, 6 to 12, looking at their suicidal rates. But it's challenging to do that research because you need more parental control and more parental support as well. Instead of being able to just do research with adults, it's a little tricky. But I do think there's some studies out there looking at younger suicidal youth, and I think like I said, everyone is at risk. I do know that emerging adulthood age, especially for my dissertation, because that's the age group that I did my dissertation on, and they were asked about suicidal ideation. It's usually called like a transitional age. So you're not longer a teenager, and you're kind of like moving into that adulthood world, and that can be challenging, especially for minorities that might have all of this layered up family responsibilities and stressors that can also impact our mental health. So I think that's definitely an age group that has struggled, and the research has supported that. I also know that there's right now I'm actually writing a paper on older adults, so 65 and older. So that's why I say that everyone in the spectrum can struggle with suicidality, and especially during the pandemic when isolation was so when isolation, when we were we were not able to go out, and we were not able to do the routines as we usually wanted, especially that community support. Like, for example, going to church for some people is definitely a support system, and for older adults that might be alone at home, the only time that they go out is when they go to church. So we looked at the suicide rates for that group, and they're also pretty high. So it's definitely not, I think, a one answer to that question. I do think that we all struggle. We're all at risk of struggling. Yes, so it's fine.
Two questions that I'm juggling with which one to go with, because I feel like you named a little bit about both of them. So let me go with the spirituality piece. Someone submitted, how do you address clients coming in with shame from suicidal ideation and then being religious? So I think that they're naming, like what you named earlier, a little bit about like how for many religious practices, suicide being a sin. And that brings up a lot of feelings of shame, like the thought that you're having any kind of ideas or thoughts or feelings around suicide. And this person specifically said, I am atheist and unsure on how to process this with the client. So there's like two pieces to that.
Yes, that is a lovely question. So thank you for whoever submitted that question, because it's definitely something to really consider. So I'm going to give a little bit of background before I answer that question, because I think it's important for people to know where I'm coming from when I answer a question like this. So I grew up Catholic. I did all my communions and confirmations and all the things that you have to do to be a good Catholic. But I don't longer practice. It's been years since I have not attended a Catholic church, and I consciously made that decision given some of my personal experience with the Catholic Church. But even then, I'm not religious. I did do a spirituality and religion psychotherapy residency, what they're calling, via Kerner counseling. So that experience, that 2-year experience after my master's, kind of helped me figure out how to work with someone whose religion is such an important part of their lives, but it might not be the main driver for my life. And first of all, I do think it's possible. So it's not because you're don't practice and you don't have the same beliefs that you're not able to support a client who does. So I think validation is so important, because clients who come in with that sense of shame, either because of the church or because of even family members maybe are being shameful towards them, or making them feel bad for having the suicidal thoughts, right? I think validation is key, just validating the fact that suicidality is, I sometimes struggle calling it like a normal part of the process, but it sort of is. Like it's definitely, when people are suffering, are having that, are in that much deep emotional or physical pain, sometimes suicide it seems like the outcome that will make it all go away, right? Because at that moment, it's just hard to see anything else, right? So I think validation to the fact that it is a normal and important reaction to consider to the pain that they're going through at the moment, I think is definitely important. And then kind of like allow the client to sit with that shame. Like, what does that shame look like? If that shame had a color or a shape, what does it show up in your body? Like, how does your body react to feeling, the shame around suicidality, and kind of help them process that? Because unfortunately, I don't think we're going to see such a big change in our time life, when it comes to religion, and kind of seeing suicide as something that's not a sin, and that is not that, I've heard so many different things about what happens to religious folks that do have these thoughts or do attempt suicide, and they're scary. I mean, they're so scary, the way that some religious groups have made you believe about suicide. And so I do think that it's valid for folks to feel shame when they're having these thoughts, and I do think that it's also important to validate as much as we can, and to know that both can be true, that you can have suicidality and you can be a religious committed person. In my personal opinion, this is all Camila. This is not opinion of any organization or institution that I be affiliated with, but in my opinion, you can have Jesus and you can have a therapist. You can have
Love that.
religion, and you can still be struggling with suicidality too. You can be a devoted Christian, a devoted fill in the blank, and you can still struggle with suicidality and thoughts. And you can be a devoted congregant of your church and still need a therapist. I mean, those things are able to coexist. So that kind of helping clients processing that shame, and what does that look like for them, and if there is any advocacy that they can do at their church, is that something that they would want. I'm not a fan to put the responsibility of our community members into changing the systems, but sometimes we can make a little bit of noise, if we start advocating. But I do think that responsibility comes from the systems that have been put in place to oppress and shame people. So.
True. With that, it kind of taps into the next question, which is, what do you tell loved ones that say that the client is only talking about suicide for attention?
Mm-hmm. Yeah, that's absolutely my favorite. When people say, "Oh, they're just asking for attention."
Yeah.
And well, it's really hard to be in that situation, because as a clinician, we know that suicidality and suicidal thoughts are important to take seriously, right? That is not someone calling out for attention, or that they're too sensitive, or they can't handle X, Y, and Z, or whatever the excuse might be for them to not believe that their suicidal thoughts. I again, like the same way that we do our clients, I think I would validate that, because what happens is, for caretakers, for parents, for caregivers, it's super scary to know that your loved one could potentially harm themselves. I mean, it's something that I've experienced at a personal level, and from caring for or talking to clients with caretakers and clients that struggling with suicidality. Like, it's so scary for them to even fathom that my child or my partner or even my friend could potentially harm themselves in a way, right? And I think all of those judgments come from a place of fear, or a place of I cannot imagine my life without this person. I cannot imagine the pain of losing this person. So I think the same way that we validate our clients, I would validate their fear and their helplessness at first, because what happens is, sometimes the tricky part with suicide, or the hard part, there's so many hard parts with suicide, but I think, there's a specific piece of people have their own autonomy and their responsibility for their lives, right? And sometimes when we see a suicide loss on the news and everything, people also have heard maybe family members say, how could they do this? Or, if maybe there's something else that I could have done to stop them. And the hardest part is that at that moment, when someone has already made the decision, when someone has already have all the access, and there's nothing you can do to change their mind, at that moment when they do play it out and do an attempt, which is so hard for family members, right? And it's so hard for caregivers. It's so hard for loved ones. So I do think that their judgments and fears is absolutely valid, and it's absolutely, I think not making them feel shameful about it either. Like, don't say things like, well, no, that's you're crazy. Like, what are you saying? Like, well, we didn't use the word crazy anyways. But just kind of validating their fears as caretakers, absolutely, because I think they're very, very valid to the possibility of losing their loved one.
Yes, which also brings us to the next question, which is, do you have any thoughts about suicide and clients having the autonomy to make the decision for themselves?
Mm-hmm.
I think that's one. I don't think we have enough of those conversations. I don't think at all. Like, when I was in my master's program as a counselor, like, I don't think it's something that's talked about. Like, yeah, just a lot of, I noticed a lot of people feel very uncomfortable with that conversation of how clients have the autonomy to make some of these decisions.
Yeah.
And a lot of the conflict of, we want to be able to help this person, and like, in what headspace is this person when they're making that decision, as well as like, overall as counselors, we are taught that autonomy is one of those incredibly important, what do we call them? Tenets? That we have
responsibilities
that we follow.
Mm-hmm.
So any thoughts, any follow-up thoughts? Because I feel like you answered a little bit of the question already.
Yeah, no, that's also a lovely question. And it's a huge debate between suicidologists, so the folks that study suicide. And because different countries also have had, I don't know, I've had to dig more into the law of things, but so different countries have had, this protection for clinicians, because clinicians are at risk of malpractice suits, right? Regardless of what of anything, we are expose ourselves, because of this work, of a malpractice suit and things like that. And And that also, whenever we lose a client to suicide in our care, I think will puts us at risk for a malpractice suit. And that happens for clinicians, for psychologists, and psychiatrists, and all that. So there's that piece of it. I think, protecting our profession, protecting our license, and all that. So I think similarly, the way that I have answered other questions is going to be like a 3-point answer, because it's not like a plain like
it's never just rigid. It's lots of spectrum.
I don't see things black and white in this work either. There's like a spectrum of possibilities and outcomes. So we embrace them all. I do think that taking into consideration the autonomy of our clients and their responsibility for their own life, right? So I think it would be too egotistic for clinicians to assume that we are heroes and we can save someone. Like it's really out of our control, unfortunately, right? There are pieces of it that are totally out of our control, unless, sometimes folks that work in inpatient care, they have more control because people are monitored 24/7. But that's different. That's different for clinicians that work at a community practice and all that. So I think the first thing is to think about it as, we can do all we can, all the interventions, all the care that we can possibly assume. But the research does show that there is a 20 to 50% chance that clinicians will lose a client to suicide. I mean, it's not something unheard of. I know many clinicians who have lost clients to suicide. So it's part of the work, I think. I also think that, for the advocacy piece of my work with American Suicide with the FSSP, we advocate for life. We advocate for people to stay here. The world needs you. You're not alone. All of those messages, right? But I do think that there is an important piece to consider when we think about who's responsible for life. Like, is there clients are responsible for their own lives ultimately, right? We can do all we want and we can in our power to support them. But unfortunately, when it comes to suicide and suicide prevention, there are pieces of it that are totally out of our control. And I think this question falls under that. I also would recommend, to always be on top of what are the practices of the place that you're working in as a clinician, because every practice will have a different kind of protocol for suicidal clients. So being aware as a clinician of what that is, because then that way you're not also putting your job in jeopardy, and also being open with that with your clients. I usually, we do all of the intake paperwork and we do the treatment consent to care and our disclosure statements and all those things. Well, make sure that during that conversation, there is a conversation about suicide and what will happen if your client mentions it, or if you are assessing for risk and you think that they are higher risk, or if that conversation, I personally have it at the beginning, so that is and sometimes clients will say no in the first session, and then life happens and things change months to months. So I think assessing for suicide and constantly is important too. But that could be a whole other topic, right? Yeah. But just kind of being aware of what are the policies and regulations around suicidality and suicidal clients in each of our locations, I think is important. And clients, therapists have clinician judgment. They will be able to use their own judgment when it comes to those things. Clinicians will, as you do the work more, the more you do the work, you will have your own thoughts and ideas about this issue. And know that it's a complicated issue, and there's not really like a right or wrong answer. I think it really does open the possibility for discussion, especially for clients, for example, who live with chronic illnesses. So, for some people, suicide is just the end of that pain, of that physical pain that there's no cure for, right? So, and they will eventually die because of that illness. So is it suicide, something that they are doing to themselves, or are they just advancing the end, for that chronic illness, which is, so that it is also important to consider when you're working with clients that struggle with chronic illnesses. There's also something that suicidologists call rational suicide. So sometimes suicidality and suicidal thoughts are viewed as a result of mental health challenges and mental health illnesses, right? So people with depression are higher risk, people with anxiety are higher risk, people with, so on and so forth. That you have to have a diagnosis for your suicidal thoughts to be valid. Well, that's not really the case for everyone. That doesn't, not everyone that has a diagnosis has then suicidal thoughts, or not everyone that has suicidal thoughts has a diagnosis, right? So what happens with folks that don't have any kind of mental health challenges, but they do struggle with suicidality, and they do because of chronic illnesses, or because of other stresses in their lives, or because of just not wanting to be alive anymore, and that's like, what is that? What does that mean then? Is that something that needs to be treated, or is that something that is part of life? And what do we do with that as clinicians? I think is an important question. And but the bottom line with all the advocacy is always to help clients to stay alive, but also honoring their own autonomy and responsibility for their own lives.
Mm-hmm. And a lot of what I'm hearing you say is also tapping into it's really important for us to do our own work. Really important for us to kind of do our own work of like addressing what are our own biases about certain topics. What is our own relationship with suicide? Have we experienced that in a personal level? Like you said earlier, have we had any clients in the past that have died by suicide? Maybe it's a loved one. Like really centering yourself in what you know about yourself, because all of that is coming into the counseling room with you as a clinician. So thank you so much. And with that, like, it brings me to the next questions. The next two questions are similar, but I think there's some nuance in them. So the first one is, most of my clients have had a very bad experience at the hospital when they have been referred there. I'm assuming when they have like suicidal ideation or a plan or something. What other options are available for clients who are reporting suicidality other than going to the hospital?
Yeah, I mean, that is real. I have experienced that as a personal, and in my personal world, as a daughter, as a sister. I've experienced it with my clients. So absolutely, and in my research actually as well. I'm currently working with a family whose 12-year-old had an experience attempt, and their experience in the healthcare system, from going to the ER, from being an inpatient, it was horrible, to say the least, right? So that's absolutely valid. Like, your clients are not alone. Unfortunately, we have a long road ahead of us in changing that systematic challenges. I do think that keeping clients safe in the moment, like when someone is at that high risk, when someone has thoughts and a plan and access, and I think keeping them safe, in a place that they could be monitored 24/7, unfortunately is the best way, is the best practice per se. But for clients that, they don't need that immediate care, I always have that, or do have suicidal thoughts, but don't have a plan or don't have an access. Because remember that suicidality is like a spectrum, it can be it can be all over the place one day. It can be in this side, it can be in this other side. Do people have access? Do people have a plan? Do people have means? Do people have a support system? I always ask, doing that safety plan, it's important. How do you do that safety plan is also important depending on the client. And trust me, it goes beyond just filling out a piece of paper, right? So it's really, I think for me, it's really more structured and more kind of involved when it comes to doing that for clients. But so do the safety plan, whatever that looks like in your organization. The same way that we're talking about policies and regulations before. What does that look like for the place that you're seeing clients at? And then ensure that clients have, for some clients that 800 number has been helpful. From others, it hasn't. It's not the greatest thing. Sometimes it takes a while to answer you back. For a while, we didn't have one in Spanish. Now we do. So there's definitely challenges around that. But if for someone that struggles with suicidality without a plan and without means and without access, having someone just to talk to outside their counseling hours or the session hours, that's not a friend or a family member, but a trained professional, I think is important. So having that that 800 number handy, it's important. And sometimes what will happen is folks will go into inpatient care and they'll come back out for care with a therapist. And I think helping people process that experience, I think is also important. Process maybe the lack of support, process how lonely it feels to be in a room, without, that's not your room, in a bed that's not your bed, all of those things, eating the food that you're not used to, all of that is important to process in their healing. So unfortunately, yes, going to the hospital is the way that we care for folks. I wish there was a more systematic change. I do think though that it depends on the severity, on the access to means, on the plan. So that's why asking those follow-up questions. Suicidality assessment is not just a yes or no answer, right? You really have to dig a little deeper when it comes to your clients so that you can know what kind of care they need. And so if going to the hospital is not available to them, or they're not at that high risk that they need to go to the hospital, then you as a clinician can do interventions that can help them. Most of my interventions, for example, are based on the interpersonal theory of suicide, which speaks to the fact that three things need to be present. The sense of the lack of belonging, so I don't belong in this world. The sense of burdensome, that I'm a burden to those around me, and the access to lethal means, right? So kind of creating interventions tailored to your clients and their needs around those three umbrellas. You can make a difference in someone's lives by doing that. So.
Okay. The next question, again, very similar, and I think it may be helpful to kind of break it down. The question was, what happens after a person who is at high risk for suicide is admitted to the hospital as a preventative measure? So I guess they're asking more of what does that look like?
Mm-hmm. Yeah, that's an interesting question. And, I can tell you my experience from when we had to commit my brother. So I've talked a lot about my personal experience, but I do have a younger brother who is a suicide attempt survivor, and the way that looked like was very it's kind of like going to an extended doctor's visit, because you're always talking to someone. So you go in and there's always people asking you questions. There's always people checking on you. But one of the things that struck me when we first dropped him off is that they had him take off everything. They put him in a gown, and they had him take off, even his shoelaces. Everything that could be harmful to him, they took away, and he didn't have access to electronics or anything like that. So I think that to me was the most impactful part of it. And that happens right at the beginning when they take your blood pressure and your temperature, kind of like it's like an extended doctor visit. So and then you're staying there for at least 7 days, I think is for everyone. People can stay longer, but it's harder to stay shorter than 7 days. I think 7 days is kind of like the unless you have a professional
That's true.
doing some kind of advocacy for you or doing extra measurements and things like that. But usually people are there for the 7 days. And during that 7 days, you are not allowed to go out, obviously, to leave the place. But you are given a psychiatrist and therapist. There's several group activities where you do group interventions and you participate with other people that are hospitalized. So you get to hear from others' stories as well. That you have a nurse assigned to you that controls your medications and makes sure that you take them at a regular time. They feed you and all that. You're not allowed to see your family as often as you can. They're visiting hours, so it's also hard for family members having to coordinate visits and things like that. So yeah, it's not an ideal thing, and that's why I'm often struck by the fact that people will say, like we were talking about before, someone is just saying these things for attention, or they're just sensitive or whatever, but it's really not. The way that we treat our people who struggle with suicidality is not a vacation. It's not like they're in an all-inclusive resort for the 7 days, right? So
that's the thing that people are not aware. Like, not all doctors, nurses, just anybody that's in a hospital setting, not everybody's trained on like providing mental health care. Not everybody's trained on suicidality, and so you're absolutely right. Like, who's going to want to go into this very sterile space where you're going to be isolated from everything and everyone too?
Yeah.
And at the same time, it's exactly like it can become the safest place for an individual if that's where, like, if we have that resource readily available. That makes me think about, you kept using the term like cultural sensitivity or cultural awareness. What does that mean, first of all, for those that don't know? And two, like, how can that look like when it comes to like suicide prevention and just providing care altogether?
Yeah. So I think, culturally sensitive services are, we talk about that when we address the cultural strengths and cultural values and traditions and experiences in our clinical work with our clients, and we ensure that our clients have access, for example, to care that is in their native language. I mean, that's the other thing that was stressful for us at that time. We had just immigrated, so my family was also working through their own acculturation process, and there was no one that could speak our native language in the setting that we went to at that time. So making sure that clients do have access to care that is in a language that they can understand, and that people are addressing the cultural aspects of the pain that they're suffering, right? Because we often just think about suicidality of like, okay, we just have to keep them safe from harm, but there's so many layers to it, like what is it that led to suicidal thoughts? What are folks struggling with in their family, in their community, that's so belonging? Like, what kind of experiences of discriminations have they experienced that have led them to this situation? And I wish that organizations and places and hospitals were more aware of those issues, that they don't only just worked on keeping clients safe, but also addressing a lot of the cultural aspects that make that puts us at high risk, for suicidality. So I think all of that is definitely important to consider. And what was the second part of the question? Sorry.
I think it's kind of related to that last question that we had, which was like, are there certain treatment or interventions that are most effective when someone is in crisis or needs a higher level of care?
Mm-hmm.
And so, and a cultural like sensitivity being part of that is what I was thinking about.
Okay. So I think, we always think about the theories of suicide, like the interpersonal theory of suicide that I mentioned before, and interventions that can be based around that, with a sense of cultural pride. Like for my clients, for example, we're so collective in a sense, but when we talk about suicide, it's something that we don't want to tell anybody because we feel so judged and stigmatized and dismissed around it, right? So as a clinician, I know that support from other people in suicide in times of crisis is so important, right? And it's also an important cultural value for us. But in that moment, when people are not wanting to talk about suicide because of all the other things, I think allowing them to find spaces that they might feel that it might not be their family, it might be another group, it might be it's something. And right now there's so many online things going on and some online platforms that can be like a support system for folks. So kind of creating that collectiveness or encouraging some of that collectiveness for clients that are feeling like they don't belong in this world, that they feel discriminated against, so they feel and that then puts them at risk for suicidality. So tailoring it is hard to answer that question in a clear pathway and give you like one intervention, because first it depends. It depends on the client, it depends on their background, it depends on, because even for me, I work with Spanish speaking clients, but my clients are from all over Latin America, so what works for my Mexican clients might not work for my Colombian clients. So I think meeting the client where they are and asking them about their cultural values, I think is key, and what has worked for them in the past, what part of the cultures are important to them, what are their strengths, what are the values that they hold dear to their hearts that could be a protective mechanism for them, right? So just making sure that any intervention that you do, whether it's CBT, DBT, I mean, all of those evidence-based interventions that sadly have not been created or tailored to our community, or with they were created with the majority community. So just kind of like making sure that you are embedding cultural factors and having cultural conversations about culture with any intervention that you do, I think is important.
All right, so I'm aware of time, and I have one question that I've been asking everybody at the end, and it's been like, there's one, if you could go back on time and like say one thing to that younger you before you started doing this work, what do you think that would be?
Just one thing?
That's a hard one. That's a hard one. As many as come to mind, maybe.
Yeah. So I think I do think that the conversation that we had earlier about clinicians are not going to be able to save everyone. Like you can't save them all. And I think because for me, going through this at a personal level, the helplessness that we talked about of like wanting to save your loved one or wanting to save your clients, it sometimes can get in the way of treatment, can get in the way of your own self-care, it can get in the way of so many things. So I think, just knowing that you will struggle with clients that are at high risk, and there's a high probability that you will have a client that has died by suicide, and that is okay. Like you're all going to have support and to I would also tell myself to not be afraid to talk about it, because I think I spent so many years early on. I'm not afraid anymore. I talk about this every day, right? in several settings and several levels. But I think I spent so many years kind of like pushing away from this work at such a deep level because of my own experience, and because it's sometimes seen as something that is so scary and harmful and so I think just kind of working through that earlier in our career, which I think is so important for master's students to be exposed to the language around suicide, the assessments, and experiences where they can help clients with supervision and support, obviously. But the earlier in our training that we can do that, I think it will save us time later on, because we're all going to have suicidal clients, or clients that struggle with suicidality. It doesn't matter what setting you're in. Yeah. So don't be afraid of it. I guess is my.
I think that's a really important one. I think so many people get uncomfortable and scared, and that discomfort is rooted in fear of talking about suicide. So it's an incredibly important point. So if people want to get in touch with you, what's the best way for them to find you?
Mm-hmm. Yeah, so there's an email. You can always send me an email to my Vacc Health email, and I think the username is CA Pulgar, so the first two of my name and then my last name, at vacchealth.edu. I'm also on Instagram, all over the place, so you can find me there at Salud Mental Health, which is like my little business thing that I have going on, because I have all this free time. So it's it's always something to do.
I'll make sure to like put those in like link them for
sure. Yeah.
Okay, well with that we're done. Thank you so much. I
You're
really
very
appreciate your
welcome.
time. I really appreciate like you sharing your wisdom with us, and I'm looking forward to like all the other work that you're doing, because you're constantly putting work out there. So
Yeah.
what we're doing.
Thank
Alrighty.
you. And if there's anyone that's interested in research around suicide and suicidality, I mean, I have a plan for the next 5 to 7 years of a research agenda that's rooted in suicide prevention and suicidality. So
absolutely.
if anyone is interested, don't be afraid to reach out.
All right. Thank you so much.
Sure. Bye.
Bye.